so we're going to get started. Hi, everyone. I'm Valerie Yeager. I'm a professor at the Fairbanks School of Public Health at Indiana University, Indianapolis, and I am one of the site PIs for the CWORPH team. I'm going to be your webinar moderator today, and we want to welcome everybody and tell you just briefly about CWORPH and introduce our panelists. Today's presentation share research from year 2 of our HRSA and CDC Public Health Workforce Research Center Award, conducted by members of our CWORPH team, or the Consortium for Workforce Research in Public Health, which is a consortium of the 6 universities that you see listed here on the screen: University of Minnesota, Columbia University, East Tennessee State, Indiana University, Johns Hopkins University, and the University of Washington. CWORPH is the home of the HRSA and CDC-funded Health Workforce Research Center, and the Health Workforce Research Center focuses specifically on public health. The work presented today is part of our Year 2 projects. We also have 2 other notable CWORPH achievements to date, including that we've been funded by the CDC National Partners Cooperative Agreement to support recruitment and retention in local public health departments, and we have completed recent national enumeration of the public health workforce. Today's session has a few tips. We'd like to use the Q&A window for questions. We will hold most questions until the end of the presentation, and there may be things that the presenters will share throughout the presentation that will answer some of those questions. The chat may be used to message the host about any technical issues, and we also have closed captioning available on this webinar. And your settings can be accessed in the Zoom application toolbar on your screen. At the end, we will have a webinar follow-up, and we will email you the slides from today that are being presented. There will also be an audio and video link for the recording of the webinar. And as well, you can subscribe to the email list for the CWORPH team and our work and our future webinars. The link is going to be posted in the chat in just a moment if it's not already there. Thank you, Nicole. I'd like to introduce our panelists for today. The first panelist is JP Leider. Many of you know JP. He is the director for the Center for Public Health Systems at the University of Minnesota. He's also the founding director He is the founding director for the Center for Public Health Systems, as well as an associate professor in the School of Public Health Division of Health Policy and Management, and an associate faculty at the Johns Hopkins Bloomberg School of Public Health. JP's published more than 120 peer-reviewed manuscripts in the areas of public health systems, the public health workforce, and public health finance. He's the Director of Evaluation for the Region 5 Public Health Training Center, and he holds a PhD in Health Policy and Management from the Johns Hopkins Bloomberg School of Public Health. We'll also have Dr. Janette Dill. Dr. Dill is an associate professor in Health Policy and Management Division in the School of Public Health at the University of Minnesota. She is the deputy director of the Consortium for Workforce Research in Public Health and is the associate director of the Life Course Center at the UMN School. Her research focuses on job quality and career mobility among the healthcare and public health workforce. It's been published in top public health and social science journals, including Health Affairs, Medical Care Research and Review, and Social Science and Medicine. And her research has been supported by the National Institute on Aging, HRSA, and other state and federal agencies. She holds a PhD in sociology and an MPH from the University of North Carolina at Chapel Hill. I'm going to stop sharing my screens, and I believe JP's going to kick us off, and he'll share his slides.
All right, folks. Nicole, could you please bring up those slides? I apologize in advance. Right before this webinar started, I lost my internet. So I'm on my phone. And I'll count on Nicole and Valerie to tell me if my audio quality is bad and I need to turn off my video. So we're going to talk today about the Public Health Workforce Calculator as a major tool for planning, and about it in context of post or
JP,
at least peri-COVID era.
JP, you may have to turn off your video because your sound is breaking up.
Oh, I'm so sorry.
That's okay.
If this continues, we may need to switch to Janette first. So let's play it by ear, folks. Nicole,
It
could you
sounds
go
good
to
now.
the next slide? Thank you. Next slide in presenter mode, please. All right. This project is part of, as Dr. Yeager said, our year 2 Public Health Workforce Research Center work, and we're not doing it alone. We're working on this project with multiple partners, with many thanks to the folks over at NACCHO for conducting the initial research to collect the data used in this presentation. And then important to say that for those who have worked on the calculator for many years, including de Beaumont and the Public Health Accreditation Board and CDC, our research is our own. Our opinions aren't necessarily those of other organizations that are party to the calculator, but just want to kind of bring that up front. Next slide, please. So we're here to talk about the Public Health Workforce Calculator, and I imagine many of you know what it is, but perhaps not all. So let's take a minute to talk through what it is and how it's used. In the middle of COVID, the de Beaumont Foundation worked on the Staffing Up project that I was a part of, and many others here were as well. The fundamental idea of Staffing Up was to figure out how many staff do we need to do the critical work and foundational work of public health. You can think of that as kind of a phase 1 of the project. In that phase, we came up with national aggregate, but folks want to know, what does that mean for my organization? So we needed 80,000 more people at the state and local level before COVID started to do the foundational work of public health. What do I need in my agency? And that's what the calculator was made to help plan for. There are a number of sources that contributed to the creation of the calculator. We'll provide in our follow-up email some materials that we've made over the years on how it was made. But what I want to mention is that there's this open question now. Is how useful, accurate, precise is the calculator in the context of COVID? Because as you might imagine, all the data were created pre-COVID that were used to make the calculator. So with our partners at NACCHO, they were kind enough to put in a part of their module, essentially a mini staffing up module that would help us look at what do folks have, what do they need, how does that compare to the calculator? Next slide, please. Fundamentally, we want to ask the question, does the workforce calculator, and especially its FTE estimates, for what's called full implementation of the foundational public health services, how concordant are they with what staff at health department responding to NACCHO Profile 22 say that they need? So to put it a bit more, how well does the calculator reflect what folks are saying they need as of 2022 as measured in the NACCHO profile? And I'll just a quick point of background here. When I say full implementation, what I mean is there's a number of areas, programs, services that are measured in the foundation structure, and we want to know, what does it take to deliver those foundational services? So how do we measure that? Next slide, please. The underlying algorithm or heuristic driving the calculator is really both top-down, bottom-up. What I mean by that is the calculator tries to understand overall how many FTE do you need, and it also tries to ask in specific programs and areas and capabilities like chronic disease or maternal child health, environmental health, but also administrative ones. What's needed there? And so that's the kind of output that you get when you use the calculator. the foundational capabilities and foundational area level staffing. What we wanted to do to kind of test and see is the calculator keeping up is to understand both current FTE allocation by area, as well as what folks felt like they would need to do their work now. So we asked, as of kind of your one of your more recent fiscal years in 19, give us actual operating expenditures and staffing, and then try and think about what you need now to do the work of the foundational public health services. Next slide. As you might expect, how the calculator is built and how the nature profile is built is slightly different. So this here, for those playing at home, offers a crosswalk between what's on the calculator versus what was in the nature profile to make sure we can get things as kind of apples to apples as possible. So you see some things are combined, but otherwise it's largely one-to-one. Next slide, please. Okay. When we look at the NACCHO profile in 2022, there were overall about 500 500 departments with staff that received this module. However, we got about 140 that fully completed the current and full implementation sections of this particular module. So that's really kind of our universe here, is going from 500 to 139 and then down to 108. We winnowed some cases where it looked like current FTEs was smaller than full implementation. And in most cases, it seemed like there might be some measurement issues there. Next slide. So overall, you can think we've got 108 health departments in our final analytic sample. And they largely, though not completely, reflect the national profile. So you can see here that our agencies are somewhat more mid-sized than small, but that in most other respects, they largely reflect the national scope and scale of our health departments. All right, so let's get into some results. Next slide. I'm going to be throwing a few graphs at you that look like this. And on the one hand, it feels like there's a lot going on. But at the end of the day, there's going to be some simple messages that come out of each of these charts. So I'm going to take a minute to explain it. You have on the y-axis what the calculator would estimate based on population size is need. And then on the x is what the folks who completed the nature profile said that they needed. The black dotted line would be a one-for-one concordance between the two. And if you've got a red line below it, that means that the NACCHO profile respondents are saying they need more than what the calculator is saying. So when the red line is above it, that means calculator is kind of overestimating, below it, underestimating need relative to what people are saying. So what can we see here? We can see that pretty consistently for smalls and mid sizes. There's a bit of a gulf between what is needed per the NACCHO profile respondents and what the calculator is estimating based on that same population size. I'll take a minute and remind those who have used the calculator before that it's not necessarily made for agencies over 500,000 staff, though it can be used, it's allowed to be used, but just made it a little bit less reliable. So we see kind of the start of a trend that we're going to talk a lot about more. Next slide. Okay. We're going to think about concordance between the specific areas and capabilities. What you can see here is that there are some that are pretty highly concordant, right? So when you see one increasing, let's say the NACCHO profile respondents saying they need more staff, you see relatively similar estimates from what the calculator is saying. However, there are a number that don't perform particularly well. And I would say these are most especially, but not exclusively, in what we'll call the foundational capabilities. Policy development and support, accountability, performance management, organizational competencies. So the thing there, as you might expect, is some of those really are quite small in terms of total staffing, and there are a number for small and mid-sized agencies where you won't expect to have anywhere near a full FTE in those areas. So I'm not necessarily surprised about the lack of concordance for those, but for the larger foundational areas, a lack of concordance would mean that the calculator might not be keeping up with where current need is. Next slide. So the last slide of results that I want to leave you with here is thinking about by foundational area and capability. Are we seeing a systematic problem, or does it kind of vary based on the area or capability? And what you can see here is that in most cases, that red line is below the black dotted line. So the folks who are responding to the nature profile are saying, yeah, I need more staff, FTEs, in these areas than the calculator would predict. Some of it's a little hard to tell because we have such a clustering of smaller agencies with expected smaller number of responses, and I'm sorry, smaller number of staff. And so the line can be a little hard to read in that case, because you see the larger jurisdictions a lot easier than you see variation in the smaller. But pretty systematically, with minimal exception like equity or assessment, we see the calculator saying that you need fewer staff than nature respondents say. Let's talk about what kind of an issue that is. Next slide, please. So we do find that, as you might expect from seeing those charts, the calculator does underestimate need for most of the areas and capabilities for full implementation. And that it happens across population bands, though I would look most closely at the small and mid-sized jurisdictions. I think there are 3 reasons for this that are really worth digging into, and we can talk more about when we get to the Q&A. The first and most obvious, right, is that the workforce calculator is based on pre-COVID data, and that need may be greater now. So notwithstanding that the nature profile was collected during 2022 and folks were still kind of in the middle of response or de-escalating, there's a very good reason to think that there had been a realization that more staff might be needed to do the work. One of the other things, though, is a little bit technical. So the second point I list here is that in the calculator, there are a couple ways where you can indicate whether your need might be higher or lower than your peers, right? So based on that, your number of staff could modulate a bit. But in this, we only took the average. When I look at who's using the calculator, generally speaking, most folks aren't saying they're all average. In some areas, they're saying higher or much higher, and some saying lower. So I think that variability is really important to consider here, because of course the nature respondents are taking into account their need, reporting it as a number, but for the calculator, it's that average is essentially normally modulated by parameters that say, well, yeah, I need more, I need less in a given area, and we can't reflect that here. And then the final one, I think, kind of cuts the other way. And by that, I mean, there's always going to be measurement error in surveys. And one of the things that we've noticed in the work we do here on capacity and cost assessments is they can be very involved. They can take weeks or months to work with folks who are doing a full assessment of their organization. Whereas what we were asking people to do in the nature profile is, in a relatively short amount of time, give us higher order answers, right? And by that, I mean, how much do you need across MCH or across environmental health? And that is kind of a different exercise. So it's not that they're incompatible at all, but that maybe with more time or technical assistance, you might have seen somewhat different answers. What I'll leave us with here that I hope to bring up again in the Q&A is not that we've got a fundamental issue with some of the workforce tools that we're using, like the calculator, that are supposed to be the starting point for a discussion about what we need in our field, but that as time goes on, as our needs change, it is very important to keep these kinds of tools up to date, so that people can get the best estimates that are possible, which is something that's underway now and can talk more about. With that, Janette, why don't I turn it over to you? And thanks everybody for bearing with my technical issues.
Hello, everyone. Let me just go ahead and share my screen here. Is that showing up as a slideshow or as presenter view? Can anyone help me?
Slideshow.
Good slideshow.
Perfect. Great. All right. Well, I'm really glad to be here today, and thank you to attendees for joining us today. I'm going to be talking about delivery of foundational public health services and looking specifically at occupations that can be used to deliver the foundational public health services and the skills that are needed. So it goes along well with JP's presentation. I want to acknowledge my collaborator on this project, Jason Orr, who I think is here. So welcome, Jason. I'm going to encourage you to jump in if you need to or want to, but he does have to head out a little bit early. But Jason was really pivotal in leading this project as well. There we go. I also want to acknowledge Harshita Karnik, who was involved in this project when it was in progress as well. All right, so what are the foundational public health services? For those of you who are not immersed in the world of public health, you may have this question. The foundational public health services define a minimum package of programs as defined by the Public Health Accreditation Board, or FAB. The FPHS framework was most recently updated in 2022 to assure that it reflects the evolving nature and modernization of governmental public health. The FPHS framework outlines the unique responsibilities of governmental public health and can be used to explain the vital role of governmental public health in a thriving community, identify capacity and resource gaps, determine the cost for assuring foundational activities, and justify funding needs. However, to best serve their communities, health departments will provide additional services and may require additional capacities in different areas as well. In this project, we focus more specifically on three particular areas, which are highlighted in green on this slide, and those include assessment and surveillance, specifically the use of data to motivate and guide public health decision-making. We focus on equity, and lastly, we focus on communications. Importantly, the foundational public health services focus on what I would call and what JP called population health services. So they're not focused on the provision of clinical services like administering vaccines or providing primary care, which is definitely something that many public health departments do, but these are specifically focused on population level services. All right, so a quick overview of the project. The aim of this study was to identify which occupations are needed to deliver population-based services in local, state, and health departments, including the typical skills associated with these occupations. The rationale for the project was to again, focus on population-based services as a core government responsibility and look specifically at the skilled staff that are needed to implement these services. There's limited evidence that exists to guide public health agencies in the development of the population health workforce, and our aim was to identify key occupations to deliver population-based services as well as typical skills within these occupations. So our research questions were the following: which occupations can be used to deliver population-based services in local and state health departments? What skills are associated with occupations performing population-based services? This was a mixed method study, so we used two methods of data. Our first was that we collected primary data with local and state health agencies with varied experience with population-based occupations. We conducted some semi-structured interviews guided by research questions, and then we used key theming of participant responses. And then our second method of data analysis was an analysis of practitioner-reported data from the Public Health Workforce Interests and Needs Survey, or PHWINS. And we looked at the perceived importance of tasks by frontline workers from the core competencies for public health professionals. All right, I'm going to report on our qualitative findings first. Our findings are from interviews with 6 participants representing local and state agencies with varied experiences. We tried to select participants that were from different size agencies. Some were from a local government, some were from state agencies. And again, we tried to vary the size in which we were recruiting from. State agencies and large local agencies had similar experiences with staffing and delivering services to populations. They had far more experience with a variety of occupations, and they were more familiar with the provision of population services. Oops, okay. Skipped ahead on accident. Small and medium-sized agencies were more focused on clinical services and had less experience with population-based services. All right, I'm going to begin by talking a bit about the workforce challenges when we're talking about the provision of population-based services. Several participants, and this is not going to be a surprise to anyone on this call, I'm sure, several participants indicated that recruitment was challenging, particularly public health nurses, PHNs, and persons with multicultural or multilingual skills. The rigidity and slowness of governmental human resources processes were broadly perceived to be key barriers in hiring, and several health departments noted making do with existing staff. Now, I have a few examples that emerged around the making do. For example, health departments described training existing staff, either clinically trained or unlicensed staff, to take on population health services roles. Examples of this included nurses trained to perform data analytics and community health workers trained to deliver epidemiology services. And then several participants described reclassifying occupations with high vacancy rates in order to fill positions. So, for example, several participants described that they were unable to hire public health nurses. They could not recruit them. They could not retain them. And so they worked to reclassify the public health nursing positions for community health worker roles or EMTs who could provide some of those clinical services. Specific occupational needs that were identified for the provision of population-based services. Small and medium agencies, in particular, described needing epidemiologists and data analysts, a challenge as they often didn't have the needs to justify a full-time position or the funds to justify a full-time position for an epidemiologist or a data analyst. So that was a challenge, and we talked with a few participants who described wanting to pool their resources with other jurisdictions in order to be able to have access to those services. All agencies described the need in particular for health educator occupations, whether that was a formal health educator role or someone like a community health worker that could work in that capacity. All right. Nearly all participants noted needing persons with strong communication skills, persons fluent in multiple languages or local backgrounds or lived experience being prioritized. And they described technical or strategic skills to support an array of activities such as data collection and analysis. So across almost all our participants, there was a real need for communication skills, for multiple languages, and for data analytics. All right, I'm going to talk briefly about our quantitative analysis. As I mentioned earlier, we use PHWINS to analyze the skills of workers across a variety of occupations, which I'll describe in a minute. We focused on 3 areas, which I described earlier, and we tried to align them to 3 of the foundational public health services areas of focus, and these included communication, data analytics, and equity, diversity, and inclusion. All right, we looked at the prioritization of these skills across 8 different occupations, and we used the qualitative interviews to identify the occupations within the PHWINS data set that we thought would be critical in the provision of population-based services. And these include community health workers, epidemiologists, health educators, policy analysts, population health specialists, program evaluators, public health informatics specialists, and data or research analysts. All of these workers are from the survey were in frontline roles as opposed to being in supervisory or administrative roles. So these are workers on the ground providing these direct services. In the right column here, you can see the sample sizes for each of the occupations. On this slide, we show the degree or the percentage of workers in each occupation that responded that these skills are a high priority for them in their jobs. And the skills are listed in the left-hand corner here, or the left column here. And they focus, as I said, on 3 areas. The first is communication, the second is data analytics, and the third is diversity, equity, and inclusion. And these are the survey items here. We found that occupations that placed a high priority on communication included community health workers, health educators, and policy analysts. And a high level is represented by this green shading here. Occupations that placed a higher priority on the use of data analytics included epidemiologists, population health specialists, program evaluators, informatics specialists, and data or research analysts. And then finally, occupations that placed a high priority on diversity and equity included community health workers and health educators. All right. So to conclude, state and large local agencies have more experience with population-based occupations. They just have more capacity, more staff, and they're more used to working with workers in these occupations. Though nearly all public health agencies reported vacancies or staffing needs, small and medium-sized local health departments had much more acute needs and weaknesses around the provision of population-based services. Certain occupations have more concordance on perceived importance of population health-related competencies, as I described in the last slides, and reflected their particular strengths and roles, and reflected the skills reflected the types of occupations that could be used to fill the needs of different agencies. All right, and that's all I have. I look forward to the Q&A. Thank you for attending, and Jason, if you're here and you want to add anything, please feel free.
Jason, were you interested in adding anything to the slides or the presentation?
Yeah, hello. Can you hear me?
We can.
Yeah, no, honestly, I think Janette, that was a really excellent overview. Obviously, I think we would have wanted, a much larger pool of respondents, a bit more depth in the data analysis that we did. But, I think the findings that we showed here indicate, that there is a bit of a need on behalf of health departments, state and local, for these population-based services and occupations that deliver those services. I think there was definitely a difference between, larger health departments and state health departments where when you think about it, they're already delivering a high proportion of population-based services. They already have a lot of these occupations in place. They just need a little bit more capacity for their work. Whereas with some of the smaller health departments, particularly those in states that have not gone as far with things like the foundational public health services and pushing that through the public health system, that there is a bit more of a need of professionals and skills related to population health services work, things a little bit different than a clinician would provide, such as data analysts and things like that.
Great. Thank you, Jason. For those of you who've submitted some questions in the Q&A, the first questions that are in there are actually questions for Dr. Leider. So JP, one of the questions that was asked was that whether or not the data could be used, the calculator could be used outside of the US. Would you like to address that topic, and whether that's something that is going to be available in the future was also asked?
Okay. I'm going to try video again. Tell me if I cut out, Val.
Yeah.
This is a really fair question, and when I get on occasion, I think the answer is a little dependent on which country we want to extrapolate it to. But the reality of the US and our both kind of decentralized state local system, but also decentralized from the feds, means that it's somewhat hard to think about how this could be used too much elsewhere. There are a lot of functions in our governmental public health that are integrated into healthcare systems abroad, especially in Europe, thinking around like clinical prevention and that sort of thing. So I think to disentangle it, it might be a little challenging. There may be some broad areas that could have kind of direct utility, but I think it would be fairly case by case. I'm thinking like environmental health would be an example of that. As for could we do it in the future, I think we have a reasonable method for how this could be done in other places. But what we're finding in the US in this presentation is that you really want as much data as possible, as up to date as possible, and as local as possible. Those are all pretty important things.
Right. So what I would like to summarize, I think you said, was that ultimately the data that the calculator is based on is all from US focused public health agencies. And so while some of it could be extrapolated, it would need to be very loosely extrapolated if it were to be used by others, because none of the data represents other settings.
Yeah,
and
exactly.
The delivery in those settings can be very different than the way the U.S. public health system is structured.
That's right.
Thank you for the question. There was also a question about the calculator, and to summarize one of the points, JP, in your slides, it seems as though the calculator is, at least for small and medium organizations, underestimating need, which is an important and interesting finding that I think we might want to talk about. But one person has said, what does that mean for how local health department leaders should use the calculator in terms of their actual needs? Does it have the ability to provide data about workforce needs that can easily be used by local health departments to make a case to decision makers that more funding is needed to staff up?
That is a great question, and probably the motivating question of why we did this project. So in finding that the calculator seems to systematically underestimate need relative to what folks responding to the nature profile said, while I think that there's a little bit of give and take there, for the reasons we talked about on that last slide, that the exercise that folks went through was maybe not quite as detailed for the nature profile compared to the cost and capacity assessments that sort of undergird the calculator. Just the amount of time that you put into it, radically different. I think there is still fundamentally something there. From what we've seen other states that have done this kind of work since COVID, need does appear greater. So to answer the question directly, I would say this is always supposed to be a place to start a conversation rather than a number that you should ask for. And looking at the data presented today, I would say that's kind of doubly true. You might think of this more as the floor now, COVID. So I would have great concern if folks are way below the floor. But also, it's worth saying out loud, you know, if that need is greater in a challenging political environment, it might be reasonable to try and shoot for pre-COVID days if you think that cuts might be deeper than that. I think in an ideal world where we're trying to be prepared across all the different areas and capabilities, thinking a bit more optimistic would be good, but nothing wrong with some prudence as well.
Thank you.
And Jason, feel free to get in there too, please.
Yeah, hi, this is Jason. Yeah, I might just note, you know, I posted in the chat there a link to tool, the Foundational Public Health Services Capacity and Cost Assessment tool. I would imagine most health departments in the United States and elsewhere have challenges with really estimating, you know, what their needs are. You know, how do you know that you need this many more FTE or which FTE for which purposes? You know, I think each of us in the position of identifying resource gaps, you know, we might see, well, you know, we think we need additional staff, but, you know, who, how many, you know, is a bit more challenging. The tool that's posted there is something that can work out pretty well. It complements the workforce calculator. There's a tab in there where it pre-fills the data that you would use to enter into the workforce calculator. You know, it definitely a little challenging to get to those data because you need to work through your staffing and where their time is allocated and things like that. But, you know, this is a good resource for that. To what JP said, you know, in terms of the calculator estimates, in our work with multiple states, many local health departments, and several state health departments, there's a tendency to overestimate your current population health services, particularly on behalf of you know, small or medium-sized health departments. There's a perception that more is being done in these population health services. But when you dig into it and ask questions and see where staff spend their time, there does tend to be a little bit more individual and clinical services being delivered, and a little bit less of those population health services considered in the foundational public health services. Similarly, when working with those health departments on estimating what they need for full implementation, there is an underestimation of how many FTEs they might need to do the things needed for full implementation of foundational public health services. So when you look at the outputs of the calculator, that gap, that estimate of need that's output is actually influenced by perhaps some subtle overestimations of current staffing by those who supply data to the calculator, and also subtle underestimations of their needs for full implementation. And that might be a part of why the estimates produced by the calculator are a little bit low. In our work with local health departments, you again, oftentimes using that Excel-based capacity and cost assessment tool, we really work with health departments to understand, okay, well, how many FTEs do you need? The calculator is a good tool to give a ballpark, but we do ask health departments to take those outputs from the calculator with somewhat of a grain of salt and think critically about what needs they might have for their community based on their current staffing and their current implementation of the foundational public health services.
Thank you, Jason. Dr. Dill, could we talk a little bit about your presentation as well? One of the things that you showed us at the end was a table that had concordance about skills or competencies and those 3 specific areas that you were looking at, which was assessment and surveillance, equity, and communication. And it seemed like there was strong concordance across assessment and surveillance, and communication, but not concordance in the area of DEI. Did I understand that correctly? Is that how you would interpret it?
That's an interesting interpretation, and I like it. I'll just share my screen so we can look at it together.
And I was making an assumption about what the color pink meant in the
Yeah.
boxes. So please correct me if any of that interpretation was wrong. And it did seem to be more folks who aren't working directly with the community, that there was less concordance in those areas, maybe folks who are behind the scenes and doing data analysis.
Yeah.
Is that fair?
Yeah, yeah. And I think the interpretation of these um, survey items, I feel like I like to hold the interpretation a little bit loosely, because if you think about how you might answer them, right, there could be a range of ways that you might interpret it, right? Um, but so the light green is a high level of prioritization of these particular skills, and then the pink is a lower level of prioritization. Now, granted, it's not that low, right? Like if you look at these, it's like this is a percent of the workforce that said this particular skill was a high priority. So our lows are in the 60s and 70s. That's still 60 to 70% of workers saying that these skills are a high priority. But for many of these skills, we're getting 95% and above saying they're high priority. So I like to point that out. It still means that a lot of workers are endorsing these skills.
I see.
Okay. Yeah, but I would say we see a lot of concordance, like you said, for both data analytics and communication across a lot of different occupations. And then the diversity, equity, and inclusion here, these are the last three survey items. We have a little bit lower prioritization across some of the occupations that are more focused, I would say, on sort of the behind the scenes work. So it's more technical workers. So program evaluators, data research analysts, epidemiologists, they're the ones who are not, out working with community members necessarily. And instead, we see high prioritization of these skills among community health workers and health educators, particularly. Does that align with, I feel like that aligns with what you had said initially.
No, that was a much better explanation. So thank you for helping us understand that. One of your other findings from your qualitative work was reflecting on hiring challenges, which I just wanted to draw some attention to the last webinar that was hosted by CWORPH related to work from our second year of funding. I put the link in the chat to the YouTube video where myself and Dr. Resnick and Paulani Mui from Hopkins presented some of the findings that we learned about hiring issues and some innovations that are being used to address some of those hiring issues. That will vary by setting. Obviously, recruitment changes depending on where you are. So if you're in a rural area, being able to resolve that issue that Dr. Dill pointed out about multilingual recruitment and things like that may continue to be challenges that agencies struggle with. But so if that's of interest to anyone who missed the previous webinar, please feel free to take a look at that.
Yeah, you're certainly the expert in the bureaucracies of hiring in public health.
And we may see some changes. There is a fair amount of change happening in our public health agencies, especially at the federal level. And so it remains to be seen what this means for recruitment in our state and local health departments moving forward. So to try and put a positive spin on something that has mostly not felt very positive, it may mean that there are other individuals who might be looking for work at the state and local level to support some of those needs and fill some of those gaps. And so hopefully some of the hiring innovations that some of the agencies are working hard on will pay off in recruiting some of those people into those settings. I want to see if anybody had anything else to add. One other question while we wait to see if there's anything else in the Q&A was if we could talk a little bit more about the data that was used and where the data comes from the first presentation. Dr. Leider, would you like to spend a moment explaining the NACCHO profile survey briefly?
Certainly. So since 1989, approximately every 2 years, the National Association of County and City Health Officials conducts a survey of their membership, which are the leaders of the nation's local health departments. There are about 2,500 that are counted by NACCHO and can report in. And of those, depends on the year, but the response rate historically has been between about 30 and 80%, depending on the year. I think they're around 40 or 50 right now, if I recall correctly. And as part of this survey, there's all sorts of things that are included: activities, finance, expenditures, workforce, information about the lead local health official. And they were kind enough in 2022 to add a module that a proportion of the responding agencies got that was on the staffing up profile. And so the staffing up module in the profile consisted of I guess it depends on how you count it, but a couple dozen questions in the form of a matrix, asking folks to weigh in on what they have in terms of staffing, what they need. And so at a fairly high level to kind of get a sense of that gap between current and full implementation or future need. So we were then able to compare that to outputs from the calculator for agencies of the same size. And that's where the charts you saw came from.
Great. Thank you so much. So I hope we've answered your questions. I want to draw your attention to our next CWORPH webinar, which is going to take place on March 12th at 1 p.m. Central Standard Time. We'll have two presentations in that webinar as well. One focused on public health workforce loan repayment program as a recruitment incentive for governmental public health departments, and that will be presented by Dr. Leider. And a second presentation on the distinguishing characteristics of public health occupations compared with the standard occupation classification codes, and that will be presented by Dr. Krasna at Columbia University and Dr. Dill at Minnesota. So the link for the webinar is in the chat. If you'd like to click that link, you can also use the QR code to register. And we want to thank you all for your attention and your time today. And thank you to Dr. Leider and Dr. Dill for your fantastic presentations. Have a nice afternoon and rest of your day.
Bye.
Thank you.